Welcome and thank you for joining me today. My systematic review presentation is on vitamin D supplementation in men and women with chronic kidney disease. Before we begin, I would like to introduce myself as the author of this systematic review. I would also like to share with you my professional background. My name is Jessica Crone and I received a Bachelor of Art in 2010 from Francis Marion University. I am pursuing my master's degree in applied nutrition and have an anticipated graduation date of 2020. I have been at my current position at Palmetto Assistance Federal Credit Union for almost 10 years. I am an assistant supervisor over the teller line and help members achieve their financial goals. By using both my education and work experiences, I would like to enter the health promotion field and help individuals have more positive health outcomes. This slide gives you an overview of the objectives that will be covered in today's presentation. I will begin by sharing some background information on the topic and continue through following the bullets listed on the screen. Chronic kidney disease, also known as CKD, is a growing health issue among men and women living in the United States. As diabetes, metabolic syndrome, and hypertension have increased in recent years, so has CKD incidence. Having CKD means that kidneys cannot function properly. Waste and extra water buildup in one's body can lead to other health issues such as heart disease and high blood pressure. According to the Centers for Disease Control and Prevention, CKD is most prevalent in individuals aged 65 years and older and impacts about 37 million adults. Additionally, CKD is more common in women than men. As these numbers continue to rise due to the growing elderly population and the increasing number of individuals with diabetes and hypertension, various management strategies are beginning to be examined to find more cost-efficient methods to decrease the rate of CKD nationwide. Recent research is starting to investigate the impact of vitamin D status and the use of vitamin D supplementation in patients with CKD, as it may play a significant role in disease management. Understanding the association of vitamin D status and how it impacts kidney function and CKD progression is essential in improving U.S. adults' health outcome. As diabetes is the leading cause of kidney disease, it is estimated that about 1 in 4 adults with CKD also have diabetes. Individuals diagnosed with diabetes and hypertension should be tested regularly for CKD to detect it early. Evidence suggests that there is an association between low levels of vitamin D and the risk for diabetes. Also, individuals can lower their CKD risk by managing their blood sugar and blood pressure, along with making healthy lifestyle changes. However, the lack of awareness of CKD and its complications keep many individuals from having more positive health outcomes. While vitamin D, an essential nutrient, is typically associated with bone health, current research shows that vitamin D deficiency is highly prevalent in CKD patients. More than 1 billion individuals globally are estimated to be either vitamin D deficient or insufficient. Experts define vitamin D deficiency levels as less than 20 nanograms per milliliter and insufficiency at 20 to 29 nanograms per milliliter. Individuals with the highest risk of being deficient in vitamin D are the aging, postmenopausal women, African Americans, and those with CKD. When individuals have CKD, they cannot properly convert 25-OHD to 125 dihydroxyvitamin D, which principally occurs in the kidneys. By not being able to metabolize vitamin D due to damaged or unhealthy kidneys, these individuals are at an increased risk for weak bones, heart disease, and many other health conditions. Vitamin D deficiency impacts people of all stages of life. Therefore, additional factors that affect vitamin D deficiency, such as race, sex, age, obesity, and impaired vitamin D synthesis and metabolism, also need to be examined in individuals with CKD. Individuals' 25-OHD levels need to be checked regularly to ensure that if they have a deficiency, it can be treated to avoid further health complications. Vitamin D supplementation should also be further examined as medical therapy, as low 25-OHD levels are reported in approximately 90% of individuals with CKD. Vitamin D has continued to be a hot topic in research as knowledge of its multiple functions has increased, and scientists have become more intrigued about the role vitamin D may play in decreasing the risk of several chronic illnesses. Many individuals may not realize they have CKD or are vitamin D deficient, as both health issues have silent symptoms. The American Kidney Fund reported that 96% of individuals in the early stages of CKD are unaware they have it, while 48% of individuals with severe CKD are unaware. When a person is diagnosed with CKD, there is a decrease in kidney function, or there is an abnormal albumin excretion, which is measured by the estimated glomerular filtration rate, also known as the eGFR. The kidneys are also where vitamin D is converted to the active form. Albumin levels can be checked with a simple urine test. When albumin or blood is found in urine, it can be an early sign of CKD. An eGFR below 60 milliliters per minute per 1.73 square meters or more, or above 60 indicates an individual has CKD. In the U.S., the incidence of CKD stages are the following: 1.8% for stage 1, 3.2% for stage 2, 7.7% for stage 3, and 0.35% for stages 4 and 5. Recent studies have found that vitamin D therapy can decrease albuminuria. Low serum albumin levels are associated with a higher prevalence of vitamin D deficiency in CKD patients. The National Kidney Foundation developed criteria to classify and assess the severity of CKD status. At the bottom of the slide, you will see the classification for each stage. The relationship between an individual's level of 25-OHD and the occurrence of various diseases is beginning to be examined to see if vitamin D supplementation will decrease the development of some chronic diseases. Through several kidney outcome initiatives, experts have found that vitamin D insufficiency and deficiency should be avoided in CKD and dialysis patients by using supplementation to prevent secondary hyperparathyroidism, also known as SHPT. One study found that low 25-OHD serum levels can further aggravate hyperparathyroidism in CKD patients. However, through a double-blind, placebo-controlled pilot study, De Boer and colleagues found that parathyroid hormone (PTH) levels were decreased by 31% in vitamin D supplementation intervention group, which is essential as chronic hyperparathyroidism can lead to more severe health consequences in individuals with CKD. Additionally, recent findings have linked vitamin D levels with various outcomes, including albuminuria, progression to early-stage renal disease, and all-cause cardiovascular mortality in patients with CKD. In another study, Bond and colleagues found that 25-OHD levels are often not routinely measured in early-stage renal disease patients. Also, when 25-OHD values below 30 nanograms per milliliter are discovered, the preliminary step should be vitamin D therapy to try to correct the abnormality. Using vitamin D supplementation is a crucial piece to ensure individuals with CKD reduce their risk of developing other health issues. This study emphasizes the importance of knowing CKD and ESRD patients' vitamin D status, as their risk for other health issues can be decreased when their 25-OHD levels are no longer deficient. Individuals with stage 4 or 5 CKD have difficulty making enough 125 dihydroxyvitamin D and may need to take a vitamin D supplementation to reduce their risk of PHT levels and slow their progression of CKD. However, since some conflicting research studies debate if vitamin D affects the progression of the disease, there needs to be additional research to determine if vitamin D has a causal relationship with improving CKD or if there is a more intricate relationship between the two. This leads us to the research question of this systematic review. The question I am looking to answer is, does vitamin D supplementation over at least 12 weeks improve GFR in men and women who have chronic kidney disease compared to those not taking a vitamin D supplement? On this slide, you will find the methods that were followed to conduct this systematic review. This systematic review investigates if vitamin D supplementation, minimum of 600 IU, over at least 12 weeks improves eGFR levels in men and women who have CKD compared to those not taking a vitamin D supplement. The terms kidney disease or estimated glomerular filtration rate and vitamin D supplementation or cholecalciferol were searched in CINAHL, Medline, the UNE Library Database, and Google Scholar. One graduate student independently screened and examined all the data populated from the article search to conduct a systematic review of the current literature between January 2010 and September 2020. Titles and abstracts of the study were reviewed to determine if they met the inclusion criteria. The same student evaluated full-text articles to determine potential eligibility. Studies that did not meet the inclusion criteria were excluded at this stage. Upon completion of the article search, relevant studies were identified. Additional studies were identified by reviewing the references of the relevant studies. The protocol of this systematic review was designed, conducted, and informed following the PRISMA guidelines. Randomized controlled trials, controlled clinical trials, randomized double-blind clinical trials, and cohort studies were included in the eligibility criteria. Studies were limited to English only and full-text articles. Studies included in this systematic review treated participants with active vitamin D sterols or native vitamin D. Interventions that were less than 8 weeks were excluded. No minimum follow-up duration was included in the eligibility criteria. Studies were also excluded from the review if they did not report an initial baseline of vitamin D levels. Additionally, studies that administered vitamin D doses below 600 IU per day were excluded from the study. Research participants met the following criteria. Participants were between 18 and 70 years of age. They had chronic kidney diseases, stages 2 through 5. Participants' vitamin D levels were less than or equal to 29 nanograms per milliliter. Also, the study dropout rate was less than 20% of the participants. The data extracted from each study included the author, title, year, study design, country, funding source, study purpose, demographic of the study population, intervention, setting, outcome data, conclusion, and the result. Each study was then classified as A, B, C, or D, depending on the strength of the research strategy, according to the Academy of Nutrition and Dietetics Evidence Analysis Manual. Each study was given a positive, neutral, or negative rating based on the quality criteria checklist, a risk of bias tool in the ANDIL manual. 7 studies were randomized control trials with a A classification. 4 studies were cohorts with B classification, and 4 studies were non-controlled trials with D classification. Upon rating each article using the quality criteria checklist, 10 articles received a positive rating, 3 a neutral rating, and 2 a negative rating. All studies reported age for participants in addition to a baseline for the eGFR and serum vitamin D levels. The majority of the studies reported gender for participants, however, study populations were mostly males. Lastly, 7 of the 15 studies did not report the race or ethnicity of the participants. The 7 randomized control trials either had a control placebo versus an intervention group taking various forms of vitamin D supplementation, or had 2 groups with each group taking a different form of vitamin D supplementation. 6 studies examined vitamin D status and the use of vitamin D supplementation in CKD patients to determine if there is an association with decreased eGFR. Other studies examined additional health conditions such as secondary hyperparathyroidism, vascular function, and kidney function in patients with type 2 diabetes and CKD patients that may be impacted by deficient levels of vitamin D. 3 of the 4 non-controlled trials only had one intervention group as the data source. The form and dosing of vitamin D supplementation varied for each study, along with the time period each group took the supplementation or placebo. Additionally, the length of the study varied from 8 to 24 weeks, while some studies had follow-up periods of 4 to 7 years to observe any additional improvements. A flow diagram, shown in Figure 1, has been included to document the search screen and selection process. 5 studies were excluded as they were not published in English, and another one was excluded as it was a review article. A total of 15 studies were included in the qualitative synthesis. Before going over the results section, I would like to briefly describe some of the studies that were reviewed. One study by De Boer and colleagues found that parathyroid hormone levels were decreased by 31% in the vitamin D supplementation intervention group, while another study from 2009 investigated using vitamin D3 therapy to raise CKD patients' 25-OHD serum levels and reduce PTH levels. Results from the study demonstrated that at 6 weeks there was a significant difference in the 25-OHD serum levels between the treatment and placebo groups. Additional studies showed that Lineage et al. Reported that patients administered vitamin D for 6 months had a significant increase in the eGFR, while the control group eGFR remain unchanged, while another study by Molina et al. Reported that with daily supplementation of cholecalciferol, there was a decrease in urinary albumin to creatinine ratio in the intervention group and no changes in the control group. In the next several slides, I will be discussing the synthesis and comparison of the results for each subheading topic. The first one I would like to discuss is vitamin D and 25-OHD levels. 10 studies reported that participants had significant improvements in 25-OHD levels following vitamin D supplementation. One study by Covesti et al. Found that ergocalciferol at 50,000 units titrated serum values of vitamin D to 30 or greater nanograms per milliliter with significantly increased 25-OHD levels after 16 weeks, but there was no significantly increased 25-OHD levels after supplementing with calcitrol group. 9 studies use cholecalciferol in various doses to improve 25-OHD levels in patients with CKD. While all 9 studies determined that cholecalciferol significantly improves 25-OHD serum levels, it remains unclear if vitamin D supplementation positively affects eGFR levels and improves kidney function. Next, 4 studies examined the impact of vitamin D therapy on eGFR. One study reported that insufficient levels of 25-OHD may be a modifiable risk factor for eGFR loss. Another study by De Boer et al. Examined vitamin D3 or omega-3 fatty acid supplementation in type 2 diabetes to determine if these therapies can prevent development or progression of CKD. Results of the study found no significant difference in change in eGFR between the various interventions, where participants were randomized to receive vitamin D3, omega-3 fatty acids, or a placebo. Additional prospective controlled clinical trials need to be conducted to determine if vitamin D therapy should slow the progression of CKD. Several studies examined the impact of vitamin D supplementation in various forms in CKD participants with either lower PTH levels or secondary hyperparathyroidism. Study participants were in stages 3 and 4 of CKD. Chauvin et al. Reported that various doses of oral calcitriol were associated with an average of 13% and 23% reduction in serum PTH concentrations depending on whether the participant received a low or regular dose. Outcomes of this study were examined between 1 and 6 months of participants initiating oral calcitriol. Covesti et al. Reported that paracalcitriol is more effective than ergocalciferol at decreasing PTH levels in patients with CKD stages 3 and 4 with vitamin D deficiency and SHPT. Of the two groups, 53% of patients in the paracalcitriol treatment group and 18% of patients in the ergocalciferol treatment group achieved the primary outcome measure. However, PTH levels in the ergocalciferol treatment group did not decrease significantly after 16 weeks. Mann et al. Reported cholecalciferol supplementation led to a significant decrease in lowering of PTH levels in non-hemodialysis patients after an 8-week intervention of 40,000 IU of cholecalciferol orally per week. However, this was not observed in HD patients. Additional studies were also reviewed that examined vitamin D therapy and albuminuria in CKD patients. Chauvin et al. Reported that a serum albumin concentration of less than 3.5 grams per deciliter was linked with a reduced calcitriol response. As discussed earlier, Lineage et al. Found a mean reduction of urinary albumin to creatinine ratio between the treatment and control group. Furthermore, in a 6-month prospective controlled intervention study conducted by Molina et al., reported that with a daily supplementation of cholecalciferol, there was a decrease in UACR in the intervention group. There were not any changes in the control group. With a reduction in albumin, there may be potential effects on delaying the development and progression of CKD. Kendrick et al. Reported that vitamin D supplementation does not improve vascular endothelial function in CKD stages 2 through 5 patients. There was no significant improvement in flow mediated dilation in either group, even after 6 months of vitamin D therapy. Kumar et al. Reported that oral doses of cholecalciferol supplementation significantly improved endothelium-dependent brachial artery flow mediated dilation at 16 weeks. These results indicated that vitamin D supplementation may improve vascular function in non-diabetic patients with stage 3 and 4 CKD and vitamin D deficiency. 4 studies of the systematic review examined CKD patients who also had diabetes. Deboer et al. Reported that insufficient 25-OHD levels may be a modifiable risk factor for early GFR loss, as rapid GFR loss was observed in 12% of the study participants. Results from this study showed lower 25-OHD levels are associated with a 25% greater risk of rapid GFR loss. Kim et al. Reported that vitamin D deficiency is more prevalent in CKD patients with diabetes, lower eGFR, and high proteinuria. Vitamin D supplementation with cholecalciferol was found to restore 52 participants' 25-OHD levels to optimal status within 3 months, while 61% restored their levels within 6 months. In this study, there was no report of how vitamin D impacted the participants' diabetes or eGFR. The objective of this systematic review was to determine if increasing serum 25-OHD levels using vitamin D supplementation would improve eGFR levels in individuals with CKD. Dosage and protocol for vitamin D supplementation varied in the included studies for this review, along with the length of the intervention. As CKD and vitamin D deficiency continue to rise, researchers will need to continue investigating the relationship between these health conditions, as one can adversely impact the other. Additional research regarding the use of vitamin D supplementation may offer new, cost-efficient, and safer ways to treat and manage various stages of CKD. Using vitamin D supplementation to treat and manage CKD may provide some economical relief, as Medicare reported that treating beneficiaries with CKD in 2017 cost over $84 billion. However, data is currently limited that addresses the association of improving low 25-OHD levels and an improved eGFR status. Patients with CKD are advised to have optimal serum levels of 25-OHD of greater than or equal to 30 nanograms per milliliter. Various comorbidities and other risk factors are associated with CKD patients with insufficient vitamin D levels. Early intervention with vitamin D supplementation is recommended in CKD patients, as Bond and colleagues found that 25-OHD levels are often not routinely measured in early-stage renal disease patients. However, evidence suggests that approximately 90% of this population is deficient. Increasing vitamin D levels by supplementation may improve additional risk factors that are related to the progression of CKD, which include urine albumin, serum creatinine, and renin levels. Therefore, correcting low 25-OHD serum levels should remain a top priority for individuals with CKD. Vitamin D insufficiency and deficiency should be avoided in CKD and dialysis patients to prevent secondary hypoparathyroidism, as this condition results in chronic stimulation of the parathyroid gland. Individuals who experience SHPT have been found to have decreased production of 1,25-OH2D. Additionally, hypoparathyroidism can lead to serious health consequences in CKD patients. The studies reviewed use various forms and doses of vitamin D supplementation to aid in decreasing PHT levels. Longer studies may need to be conducted to determine the long-term impact of sufficient 25-OHD levels of SHPT. Lastly, as most studies use different protocols, doses, and intervention times, I found it difficult to compare studies against one another to determine a consensus on which study design might be best used for future research. CKD is a complex medical condition with many contributing factors and needs more concrete evidence that provides the best route for preventing and delaying the progression of CKD. The purpose of this systematic review was to develop a better understanding of the connection between vitamin D levels and the progression of CKD in men and women. While most study populations consisted of men 55 years or older, by 2030 it is estimated that 38 million people over the age of 30 years will have developed CKD. Therefore, examining younger adults at risk for developing CKD is critical as well. Due to the increasing number of people in the world who have vitamin D deficiency, it is important to fully understand the role that vitamin D plays in overall health and how it can be used to prevent and treat chronic illnesses. This current review concluded that there is not enough data to determine if vitamin D supplementation can improve eGFR. However, there are several studies that suggest by improving vitamin D status, numerous other risk factors may be decreased, which may aid in delaying the progression of CKD. By getting individuals' 25-OHD levels back to optimal status, they may also see a change in other health conditions that may they may have. Through the use of vitamin D supplementation, there is hope to alleviate some of the economic and societal consequences of vitamin D deficiency, such as CKD and other health disparities associated with it. Vitamin D supplementation is an easy and inexpensive way to increase vitamin D levels when individuals are deficient. Also, nutrition professionals and healthcare providers can encourage their CKD clients and patients to know their vitamin D status, recommend them the proper supplementation if needed, and continue to educate them on the importance of having optimal levels of vitamin D, as it is not necessarily something that is associated with CKD. This systematic review included a comprehensive literature search on the most recent evidence-based studies conducted within the last 10 years regarding vitamin D and CKD. By expanding the time frame to 10 years, allowed for more vitamin D supplementation interventions to be included. Also, the studies provide great insight on how 25-OHD serum levels impact various risk factors related to CKD. As far as the limitations are concerned, there are not enough studies that report a positive change in eGFR to determine whether vitamin D supplementation can delay the development or progression of CKD. Another limitation that was not addressed in most of the studies included in this review was noting the season of the year, as decreased sun exposure can lead to decreased vitamin D levels. Also, due to specific search terms being used in the various databases, it is possible that not all the studies that met the search criteria were included as part of this systematic review. In conclusion, from conducting this systematic review, more research is needed to determine if keeping optimal levels of vitamin D will aid in slowing down or reversing CKD progression. 10 studies reported vitamin D supplementation significantly improved 25-OHD levels, yet most did not indicate whether a positive impact was made in relation to eGFR levels or kidney function. However, 3 studies showed vitamin D supplementation had a positive impact on eGFR, while 1 study had no significant difference. 4 studies found that vitamin D supplementation is an effective method in decreasing PTH levels, while 2 studies had conflicting results in determining whether vitamin D supplementation is effective in improving vascular function in CKD patients. Additionally, 3 studies reported that vitamin D supplementation had positive impacts in lowering albumin levels. 4 studies regarding vitamin D therapy and diabetic nephropathy examined how increased levels of 25-OHD can improve various risk factors of both diabetes and CKD. Therefore, even if vitamin D cannot be found to slow or reverse the progression of CKD, maintaining optimal levels is crucial in decreasing other risk factors in this population. Further studies may examine other factors that may impact CKD, such as demographic, socioeconomic status, and lifestyle factors. It may prove to be beneficial to have a more extended treatment intervention, since there are many complications and facets of CKD as it is developed over the years. Also, few studies utilized a control and intervention treatment group, yet rather examined a larger population in their study. Having more consistent methods to conduct these studies may aid in providing a better consensus on which supplementation and dosage will not only restore 25-OHD levels, but also help prevent CKD progression in all adults. This concludes the presentation. References for this entire systematic review are provided on the next several slides. Thank you for your time and enjoy the rest of your day.